All right, now let's look at arthritis. You remember from the first lecture we talked about from the first introductory lecture we talked about arthritis, and we talked about that in terms of the money that's spent by the government looking after this disease. This is a significant proportion of the health budget, so it's a significant burden of disease. The government tries to spend a lot of money in public health to try and prevent these conditions from occurring. What does arthritis mean? Arthritis means arthri from joint, then tis means inflammation. Mainly, if you remember from the first slide when we talked about joints, mainly this occurs in synovial joints. So those are joints which are freely movable. Not the fibrous or the cartilaginous joints don't cause much of a problem, but the joints which are freely movable, they are the ones that elicit a lot of pain, and they are the ones which cause much of the symptoms that we see in patients who have got arthritis. Arthritis has got different types. Osteoarthritis, which we'll look at first, and then we'll look at rheumatoid arthritis, and we'll briefly discuss gout arthritis. The more significant ones are osteoarthritis and rheumatoid arthritis, and again it ties in with the burden of disease and with the health priority areas. Gout arthritis is not as significant, but we'll talk about it briefly. Then childhood arthritis, good to know that it exists, but we won't go in any detail about that. But you should also know that there is idiopathic rheumatoid arthritis. There's another condition which I won't discuss here, but which you might actually see when you read your textbooks. They also talk about lupus erythematosus, lupus disease. So this disease also has got a multi-system presentation, very difficult to diagnose, but also causes joint problems. So it's sometimes classified under inflammatory disease, general inflammatory conditions. It's also classified sometimes under diseases which cause musculoskeletal problems. But we won't talk about it in detail here, but it's covered elsewhere. So the main conditions that I would want you to concentrate on as far as the studies are concerned is osteoarthritis and rheumatoid arthritis. So let's start with osteoarthritis. What is it? Even though the condition, we know that osteo means bone, then arthri means joint, then tis means inflammation. In fact, the most common form of arthritis, there is no inflammation at all. There's just joint degeneration, and it's not a non-systemic disease, so you won't get any inflammatory markers. You won't get a change in temperature. You won't get a change. You won't get a change such as swelling, those signs of inflammation that you see in most patients. So osteo means degeneration of joint disease characterized by destruction of the articular cartilage and bone overgrowth. Many joints go under degenerative condition, degeneration progressively, but most of them are the weight-bearing bones. So what do you see in this patient? The stiffness, tenderness, crepitus. This is what you call the bone-on-bone phenomena. So you can hear the bones rubbing against each other. That's what we call crepitus. And there's sometimes overdevelopment of the bones due to that, and then there's deformity and dislocation which can occur as a result of that. What are the people at risk? Advancing age, decreased muscle strength. So exercise is important, but over exercise can also cause damage to joints. And obesity is a problem because it increases wear and tear on the joints, especially the knees. The knees are likely to develop osteoarthritis as a result. So there's a case in point there for losing weight. Then there's a potential for genetic predisposition. Earlier in the disease, it's difficult to diagnose. Much of the osteoarthritis depends on getting a good history from the patient, such as trauma to the joint would give you a good indication. I said before that whenever when you're getting the history, you want to know whether bilateral joints are affected. And normally in osteoarthritis, you've got one joint affected and the other completely alright. So you can, some people talk about a bad knee, for example, a bad arm, for example, a bad elbow joint, for example, not bad elbows or bad knees per se. So a single knee could be a problem. So usually osteoarthritis is not bilateral. So it only affects one joint, and that joint is associated with overuse of that joint. So in a primary osteoarthritis, you don't know the cause. In secondary arthritis, you know the cause. For example, in sports people, so the joints wear over time, and then there's joint on joint phenomena. I showed you an X-ray earlier on, which exactly looks like the picture here. In which the bones, the knee joints are sitting on each other. In the picture, the caption on that picture was an evil kiss. So because what happens is that when those bones start rubbing against each other, not a good thing. They keep destroying each other and restrict movement. So this is an example of a normal hip joint and an arthritic hip joint. So what are the signs and symptoms? So there's joint pain, decreased range of motion, crepitus, which I've explained. There's also some nodules. Nodules are mainly seen probably on the distal ends of the joints or on the proximal ends of the joints. And there's a feeling of locking, there's cracking of the joint, and there's decreased flexibility of the joint. How do you treat osteoarthritis? So mainly it's pharmacological management. Sometimes the non-inflammatory substances do work to reduce pain. Because what happens, although the disease is not inflammatory itself, but however, once there's now starting to be damage, then that triggers inflammation, and that inflammation can be reduced by medication. Then there's also intra-articular injections such as corticosteroids, which are helpful, so which reduce inflammation. Glucosamine can act as a lubricant. Rest. Putting some braces and splints, applying heat therapy to the wound. Generally, on the long run, an arthroplasty is sufficient to treat the joint. So this is where they remodel the joint again with a new surface, so that they have got smoother flow. This is where you would need private health insurance, because waiting for an arthroplasty, if you're a public patient, is years. And if you ask the patients in hospital, they will testify to that. Then rheumatoid arthritis. Rheumatoid arthritis is different. So we talked about osteoarthritis. Rheumatoid arthritis is different. Rheumatoid arthritis is a progressive inflammatory disease, but there's also degeneration of joints and deformity of joints. It's you will see the swelling, you see the redness, you see the fever in the patient, you will see inflammatory cells accumulating in the fluid, you see joint swelling. It's classified as an autoimmune disease. There is exacerbation of the disease, and there is remission of the disease. Sometimes you knock it off, it disappears, and then it comes back, but never disappears completely. It causes deformity, severe deformities of the joints. What are the risk factors? Mainly females aged 20 to 50. There's a strong genetic predisposition, but we're starting to see virus associated with rheumatoid arthritis, such as Epstein-Barr virus and stress. The symptoms are swelling, simultaneous symmetrical joint swelling. So this is where I was giving an example of that of a big difference with osteoarthritis. Because osteoarthritis affects one joint, whereas rheumatoid arthritis, you have got bilateral joints affected. So you can tell the difference there. There's fever, there's weight loss, there's fatigue, there's anemia, there's lymph node enlargement, there's nodules as well, as you would see, but the nodules are much more bigger in in rheumatoid arthritis. There is Raynaud's phenomena. Raynaud's phenomena is where you've got decreased circulation, and there's discoloration of the hands due to decreased circulation. Not much circulation there going to the hands as a result of the arthritis. So now, how do you diagnose it? It's non-specific, very difficult to diagnose, especially earlier on in the disease where you don't have all these deformities, you just have got mild complaints. But one of the diagnostic features is a rheumatoid factor antibody. So you take a blood. Also, you can see the inflammatory markers raised. There's antibodies raised, and if you aspirate joint fluid, you also see a rise in white cell count and a rise in inflammatory markers. So these are some of the diagnostic procedures that could be used. So here we've got some pictures of the nodules at the back, nodules in the hands. That's our common sight. You remember this X-ray from the introductory lecture, which I asked you what does it mean. So this is here an example of a patient with there's bilateral, so both hands are affected, and they are almost a mirror image of each other. So which is striking, which is a significant sign that this is rheumatoid arthritis. So the rheumatoid factor, so this is how it's taken. Joint aspiration, this is how it's taken, and normally when you take a joint aspirate, the fluid is cloudy, it's milk, it's dark, and contain white blood cells, and shows you that there's inflammation going on there. So that's a difference again from osteoarthritis. So in rheumatoid arthritis, you see that specific inflammation going on. Now the treatment of osteoarthritis, I'll go in detail a little bit about these medications, because they are quite specific to rheumatoid arthritis, and you will see most of them in hospital, and you look after a lot of patients with rheumatoid arthritis in hospital. So what are the medications which are used? They use NSAIDs, disease-modifying anti-rheumatoid drugs, corticosteroids, and biological modifiers. So let's start with non-steroidal. So those are the aspirins, the ibuprofen, the naproxens. They need to be used with caution. They've got a lot of side effects. Some of the side effects are nausea, vomiting, diarrhea, which are the simple ones. But however, the with more prolonged use, these patients are at risk of bleeding. So prolonged bleeding and ulcers. Now you also have the corticosteroids. Corticosteroids are immunosuppressants, so they suppress the inflammation caused by rheumatoid arthritis. But long-term use of immunosuppressants causes osteoporosis, which is a bad thing. Again, you've got a problem which is affecting joints and bones, and then if you put osteoporosis on top of that, then there's it just exacerbates the process. And again, the corticosteroids affect your metabolism. They affect sugar levels. They put you at a risk of infections as well, because of suppression of inflammation and suppression of immune system. So they are not, but they have to be used for the disease. Then you've got the disease-modifying anti-rheumatoid. Methotrexate is the gold standard for this treatment. Here you see a lot of patients taking them. Methotrexate, it is an immunosuppressive it has got an immunosuppressive activity, and there's got similar side effects to someone who's taking corticosteroids, because at the end of the day your causes ulceration, causes anemia, damages liver. It's a highly toxic drug. Some of the other drugs in this category are also cyclosporin, sulfasalazine, and azathioprine. So you see some of this being used in hospitals. Then there's the newer drugs which are being used, the biological response modifiers. Not so new, but at least new. They have got an activity. They actually work by also suppressing your immune system. They improve they've got a very good response to rheumatoid arthritis, which is a good thing. But however, they also thin the skin, they cause mood swings, they cause osteoporosis, and they can worsen diabetes mellitus, which is not a good thing. So all these conditions, medications which are taken for rheumatoid arthritis, they've got negative side effects which are quite significant, which need to be monitored closely for all the patients who are taking these medications. You got the natural therapies. Some of them work, some of them don't. You see patients taking them in the hospital as well. And you might need to look at the interactions with, especially with omega-3, which affects clotting. You might need to make sure that if the patient has been put on blood thinners, you look at that too. Then other treatments are rest, range of motion, cold therapy, ultrasounds, exercise, heat and cold applications. Then of course surgically is total replacements, hip replacements, and arthroplasty might help, and also synovectomy, so might also help with the treatment of this condition. Now, lastly, we look at gout arthritis. So, very painful inflammatory. In the primary condition of this neck, there is an inborn error in uric acid metabolism, which increases production and interferes with excretion of uric acid. So, uric acid is a byproduct of protein metabolism. So, protein metabolism, as it occurs, generates uric acid, and which is excreted by the kidneys. But if there is a problem in its metabolism, then there's accumulation of uric acid, and then if uric acid accumulates, then it crystallizes and causes stones, and then these stones, which appear as trophies on the skin, on skin patients, then they trigger inflammation, and then if it happens in the joints, then it might trigger arthritis, so inflammation of those joints. In secondary, this is hyperuricemia, accumulation of uric acid caused by overeating of meat, for example, red meat especially, or other conditions which can affect that. So now, how is it treated? So you treat with medications. One of the medications that you see a lot with patients is allopurinol, which prevents formation of uric acid and decreases uric acid. There's also choquinine, with very severe side effects, causes diarrhea. NSAIDs could be used for as well. Glucocorticoids could be used for. Diet is a good to take. Diet rich, which excludes rich, such as use of organic meats, less red meat, sardines, and red wine. So avoid aspirin and diuretics, which can precipitate a gout attack. And some of the gout attacks appear early in the morning and sort of decrease during the day. So this is gout. So this concludes our lecture. Thank you.